So, so first, I want to thank my colleagues at the Maya Lab who have contributed to this talk. So what I'm going to talk about is the data noise due to the human subjectivity. Like Tom and Brian and everyone said, yes, you need high quality data, large N2, but in reality, we often have to deal with noisy data sets. And there are a lot of research there trying to address this problem. One type of noisy annotation problems are expertise errors. That is the inconsistencies between different observers due to the human subjectivity. And the conventional wisdom, that's what we heard so far, dealing with this type of noisy annotations, one is to achieve consensus from a group of expert observers, right? Typically, you look at all these high impact journals, journal papers, they claim they have so many expert observers, they achieved consensus on these labels, right? Or they have a super expert who made the final decision on the label. Also, there are ways to mitigate the adverse effect during the model training. So that kind of assume there's a ground truth there for the labeling of the data. And the noise from the lack of experience, errors, whatever you make. So with training, with additional training, with the assistance of AI, this type of variation can be reduced. So that's what everybody thinks. But in the real world, in clinical practice, there is not always a single ground truth. There could be multiple ground truths, right? And that's because the lack of information, because this is a underdetermined problem. There are two major sources for human subjectivity-related data annotation noise. I call it type A, that's because of lack of experience. Type B, that's because of lack of information. For type A noise, the clinicians do not know how to do it right. That would lead to this type of noise around each ground truth. And then with the increased experience, for example, with the increased physician experience, so this type of noise will reduce. And also, of course, you can give them additional training, and also you can develop AI tools to help them reducing their variation in their clinical practice. And we have seen some work, for example, for the clinical target segmentation in radiotherapy. If you segment the target first with the AI, then you ask them to modify the AI contours, the variation among physicians can be reduced. So that's, I call that type A type of noise. But then there is type B, that is based on the different practicing styles from the different training background, personal experience, and preference. There are three main reasons for type B variations. B1, that's because they are from different training background, right? Then this is more like a habit, and they don't want to switch, but if you force them to, like at certain institutions, there's a policy, hey, like for example, Anderson, in the same disease team, you have to use the same so-called ground truth. We can still do that, right? But there's another type that is actually lack of evidence to support one single ground truth. And the clinicians there, they are experienced. They believe what they are doing is right. Like Brian was saying, knowing without evidence is a faith, right? So they have that kind of strong faith, and they don't want to change unless you show them there's a clear evidence. The other way is better, but a lot of times we do not have that kind of evidence, and the difference in their practice styles is kind of one of the many compounding factors, and there's no easy way to have clinical trials or whatever evidence to show that one way is better than the other. Type 3 is even more challenging because that's from the trade-offs, like between many factors. such as tumor control and toxicity, right? That's personal preference for patients, also for clinicians. So essentially, there's no way you can reduce that type of variation in the data labeling. So this type of type B variation is what I'm talking about. We should expect in order for you to introduce AI in the clinical practice. Otherwise, you're going to have a failure for the AI deployment. So why there is such a type B noise? Because AI is still an art in many cases. I'm sorry, it's AI. Medicine is still art, sorry. Evidence-based medicine and clinical guidelines are only give physicians the floor, not the ceiling. So physicians still have room to exercise their own judgments. Therefore, variation exists in physicians' clinical practice. And there, like I mentioned before, there's often no ground truth to tell you which one is the best. And also there's a trade-off, right? Life is full of trade-offs, right? It's always a Pareto optimization problem. So that causes variations in practice. I use this post-op prostate CTV segmentation as example, right? So the prostate gland has been surgically removed here. There are residual tumor cells. We need to use radiation to kill those tumor cells, but those tumor cells are not visible in CT or MR images. And this is a different type of segmentation problem because there is no boundary of the object defined by the image contrast, right? So then you have to follow like a guideline such as RTOG guideline and use relationship with other organs, use pathology reports and all the information beyond the images to segment the boundary of the CTV. And you can see here for this particular patient, we have 4 contours of the CTV from 4 radiation oncologists working in the same group at the same institution, following the same guideline, right? There's still variation there. So we developed neural network, deep neural network for the automated CTV segmentation using the information I mentioned. We got reasonable results. Then we did an observer study and we compared the AI segmentations versus the resident segmentations. You can see this is a resident dice score minus the AI dice score is dominantly negative. So that means AI outperform the residents all the time, most of the time. So this type of variation among residents, that is a type A type of variation, right? That can be reduced with the help of AI, with the training, that kind of stuff, right? We did another observer study. We presented the AI contour and the clinical contour. So this is a retrospective study. The clinical contours were used for patients' treatment, right? So we presented the attendees, they are supposed to be experienced, practicing physicians, right? With both contours in a blended random way. So they don't know which one is which, right? And we asked them to score from 1 to 4, 4 being the acceptable without changes, 3 minor changes, 2 major changes, and 1 is unacceptable. And also we asked them to identify which one was the contour we used for patient treatment, right? So we found out they gave an average score of 3.4 for the clinical contours when you look at their own patients treated by this particular observer. Of course, they did not know that because it was a blended study, but they liked their own work. Cited better than AI, 3.4 versus 3.2. 60% of the time, they like their own work than AI's, but still not too far from the AI's work. But when they look at their colleagues' contours, the colleagues are in the same group, right? Working in the same group, using the same clinical guideline. Apparently like AI's contours more than their colleagues. 75% of the times, they think AI did a better job than their colleagues. So that's very interesting. Apparently, there's a difference among those 4 radiation oncologists in segmenting CTV. So then our next question is this physician style consistent and learnable? Then we use their names as labels to train a classifier. And we found out you can achieve 85% of accuracy, which means you present the computer with a CT image and the CTV contours. The computer can tell you which physician did the work. So there is a consistent and learnable style in segmenting CTV. Then the next question is, what is the consequence on patient care? What is the correlation with the outcome and the toxicity? So we did statistical analysis. We found out, I think, fortunately, there is no correlation with the outcome and toxicity. So, which is good. So the physicians were quite worried when we were working on that. So then, but the problem is, well, if there is no correlation with the outcome, then I don't need to change, right? And they don't want to change. In that case, if you give them an automated segmentation AI tool for CTV segmentation, if you train the model with all 4 physicians' data, you essentially give them an average contour, and no one will like it. They have to manually revise it every time, and then eventually they're going to give up. This is not what I want. It's not helping me, right? I have to manually revise it. Then my lens will just segment the CTV from scratch. So that's considered a failure of your AI deployment, right? No one wants to use it. So to solve that problem, we developed a PSA-led physician style aware network. It's a very simple idea. Use the same encoder for all the physicians, but you have multiple decoders when you train the model. So each decoder corresponds to one physician's style, right? Very simple idea. So this is an example, right? If you look at this image, the red contour is from this particular physician's contour, and the blue one is from, if you train a model with like a mixture of the data from different physicians. Apparently they don't like it, how to treat the blender here. Every time they have to revise it, then they don't want to use it anymore. However, if you use PSA-led, it will give you this physician the pink contour that is exactly their own style, right? His or her own style, and then they can just use it for patient care. So we did the external validation with Mayo Alranas data. Same thing here. Their own physician's contour is in red. And if you give them the UT Southwestern model, that is in cyan, quite different too. And then with this PSA-led, you can give them what they want, right? So then, I mean, this is just one example, CTV segmentation, which of course is an important problem in radiotherapy because that's the target where you deliver your radiation to, right? If you don't have the right target, all the work we do in radiotherapy doesn't make sense, right? Because you deliver radiation to the wrong place. However, there are many other clinical tasks in medicine, I think share the same type of problem. There are a lot of variations among experienced physicians' practice. And what do we do when we implement AI in a clinical routine, right? We cannot just simply ignore that. We just cannot just simply think that's noise, data noise. We should force them to, practice in the exact same way. That's not going to happen in the near future or later. Right? Depends on the type of the source of the variation. So in order for successful implementation of AI, we propose to use something similar to this PSA-led, meaning you give them what they want by default, like this CTV segmentation. However, with a mouse click, they can have easy access to other physicians' style. Maybe sometimes they are not very sure how to handle this patient, but with a mouse click, they can know, okay, this expert in Anderson or Stanford, how this expert would treat this patient, right? They will have that solution there with a mouse click. So I think in long run, if you have this kind of tools developed, first, they get what they want by default, so that will improve their whatever efficiency. But in long run, with this availability of experts solutions for treating the same patient, then I think this is also, especially for resource limited regions, inexperienced physicians, this is going to be a very useful educational tool. So I want to thank you for your attention. Any questions?
Thank you very much. Are there any questions for the speaker, sir?